My dear students, as I close the University of Washington and School of Nursing chapter on my career, spanning 30 years as a graduate student and employee, I wanted to share a bit of my own journey and thank you for the many wonderful contributions you've made to my life. My own nursing journey began in the small town in which I grew up. It started in 4th grade, although I didn't know it at the time. I remember walking into Mr. Hansen's classroom for science and seeing the desks arranged in small groups. In the center of each cluster was a package of white butcher paper. Mr. Hansen explained we would be studying how the heart works and asked us to open the packages. Inside, to my amazement, was a pig heart dissected from the apex up to the aorta and including an inch or two of the great vessels. This allowed for visual and manual exploration of all the chambers and great vessels. I don't remember much about the discussion, but I do remember that my 9-year-old brain was on fire with a million questions. I had never really thought about how my body or brain worked. Yet here in front of me was a vital organ necessary for life, and I wanted to know how it worked. I'll admit, I was hooked. At the end of class, Mr. Hansen offered to give a heart to any student who wanted to take it home to study in more detail. My hand shot into the air so fast, I was the first to claim one of those prizes. I took it home and immediately put it in the refrigerator with much excitement about exploring it in more detail later that evening. I'm sure my mother was shocked, confused, and probably a little grossed out when she opened the mystery package for the first time. Perhaps my parents thought the novelty would wear off after a couple of days, but it didn't. Fortunately for me, they were supportive of my interest in all things medical. They bought me a set of Young People's Science Encyclopedia that I labored over in great detail at the kitchen table in the evenings. I was particularly fascinated with the chapter on the brain. I remember reading about Broca's area and its relationship to speech and wondered how in the world scientists and doctors knew this. The more I read, the more questions I had, many of which are still unanswered for me today. So I became that science geek of a kid who read about brains and cancer and exotic diseases and made brightly colored, foul-smelling concoctions with my little chemistry set in the basement. I'm pretty sure there was nothing too toxic in it, or my parents would not have left me alone to play in the basement. And while my brother was putting together models of airplanes and tricked out cars, I was putting together a model of the visible man, showing the entire circulatory system and other organs. Although I grew up in a very small town in eastern Washington state, I was extremely fortunate to have excellent science and math teachers in high school. I took all of the math and science classes that were offered and intended to major in pre-med in college. During my junior year of high school, all students had to take an aptitude test. My top 3 career choices came back as nursing, healthcare, and the arts. I must admit, I was a little insulted and disappointed and wondered if I had listed my gender as male, whether my first choice would have come back as medicine. I was set on becoming a doctor, so in the fall of 1979, I headed off to Washington State University to major in pre-med. My math and science grades weren't bad. However, advisors discouraged me from pursuing medicine because I was not at the top of my class. A number of obstacles presented themselves, and after 2 years of getting confusing and sometimes negative feedback about my academic abilities, and having changed majors 3 times, a friend suggested I take a look at nursing. Again, I initially felt a little insulted and disappointed in myself, like I was somehow settling for less. But that's because I didn't know what nurses do, and I didn't understand the power of nursing. I looked at the prerequisites for admission to the nursing program and discovered they were all things I was very interested in. It made sense to me that since these were prerequisites, this was information I would be using in my career, and I thought perhaps I had misjudged the profession and should give it a chance. I still had 7 prerequisites left to complete, so at the beginning of my junior year, I registered for a number of them, began whittling away, and applied for the nursing program, knowing it was very competitive and probably a long shot. Fortunately, the universe was looking out for me and pushing me in the right direction. In May of 1982, at the end of my junior year, I received a letter of acceptance into the nursing program at the Intercollegiate Center for Nursing Education in Spokane, a consortium of nursing students from Washington State University, Eastern Washington University, Whitworth College, and Fort Wright College. I moved to Spokane in the fall of 1982 and shared a place with my brother, who was attending community college. Nursing school was challenging, fascinating, mind-blowing, and scary all at the same time. For 2 years, it completely consumed me, and while I loved everything I was learning, I was quite sure I would never learn enough to be a competent nurse. During the second semester of my first year, I had my first psychiatric clinical rotation at Eastern State Hospital, and something just clicked for me. I knew this is what I was supposed to be doing. While all of my patients were significantly compromised in their cognitive and emotional functioning due to their mental illness, or in some cases traumatic brain injury, they were still people with rich life histories and unique personalities that drew me in. I saw how painful it was for them to have lost their former selves, and in some instances, their ability to even communicate what they were feeling and thinking in the moment. But I knew that I could connect with that part of them that was lost. While I might not be able to bring it back, I could celebrate and validate them as unique individuals and help them stay connected to their own journey. While their care needs dictated placement in a facility like this, it was sad to see them discarded, like treasures their friends and families had lost interest in. Although young and idealistic, I hoped that acknowledging their stories and treating them with dignity and respect might help them maintain their self-worth. In my final year of nursing school, I had 2 experiences that profoundly shaped my nursing career. The first was a clinical rotation working in community mental health. I was part of a program that provided training and support for foster parents interested in fostering teens with significant trauma histories, mental illness, and substance use disorders. I spent a semester working with one family who were fostering a 15-year-old girl. When I realized I could actually do this for real as a nurse and get paid, I was so excited. I could see myself doing this for my entire career and knew this would be a goal I would pursue until I had attained it. The other event that so profoundly affected me was I experienced the power of nursing for the first time, but not as a student, as a patient. I played City League volleyball during nursing school and suffered a knee injury that required surgery. I was going to have spinal anesthesia and be awake for the procedure. Because I was a nursing student, I knew enough to be terrified of all the potential complications of having a needle placed in my spine to inject anesthesia into my spinal fluid. I was given the usual pre-anesthesia oral medication and wheeled in to receive anesthesia. I was lying on my left side and had my eyes closed, concentrating with everything I had on staying relaxed. The anesthesiologist and an OR nurse were standing behind me when the nurse said to the anesthesiologist, "What did you give her? She's out already." I said, "I'm awake. I'm just trying to relax." The nurse didn't say a word, but reached down, took my hand, and held it until the anesthesia was complete. I never knew her name, and I couldn't see her face because she was wearing a mask. But that one gesture was more powerful than anything she could have said. Although I knew I would become a psychiatric nurse and my role would be different than hers, I vowed that I would try to find a way to provide that same sense of care, understanding, validation, and support for my patients. That was the kind of nurse I wanted to be. As I was approaching my final year of nursing school, the class that graduated ahead of us relayed information that the nursing job market was so flooded it would most likely take 6 months just to get an interview for a night shift position on a general med-surg unit. The thought of returning to live with my parents in a town of 1,600 people while waiting to get a night shift med-surg job, something I wasn't even interested in, that would most likely require me to continue living with my parents and commuting to Spokane an hour away, was just something I couldn't imagine. So although I had absolutely no aspirations to military service, when the military recruiters came to my school, I thought, what the heck? Not what I ever pictured for myself, but it's a job. The Navy, Army, and Air Force sent recruiters. I didn't bother talking to the Navy since I'm somewhat claustrophobic and couldn't imagine being stuck on a ship. The Army offered an assignment in either North Carolina or Georgia, working in med-surg for at least a year before having the opportunity to request to cross-train into psych. I wasn't thrilled about either location or the work, but it was a job. The Air Force offered an assignment in Texas and a guaranteed psych position. While I wasn't thrilled about the location, the prospect of starting in psych won me over. I would not be commissioned until the end of the year and would start officer training school in January. I worked at a summer camp after graduation and lived with my parents for 4 months before heading south. I was initially assigned to Shepherd Air Force Base in Wichita Falls, Texas for several weeks of officer training and made the drive there in January of 1984. After completing my training, I was assigned there to work on a 30-bed inpatient psychiatric unit for 3 years. The hospital was a 150-bed facility that was primarily psychiatric. In addition to my unit, there was a 20-bed inpatient psych unit and a 48-bed alcohol rehabilitation unit. The hospital also had a small ICU and emergency department, in addition to medical beds, with only 4 of those being pediatric, limited OB, and full-service outpatient clinics. We were a hub for psychiatric evaluation and treatment for all 4 branches of the military. Because there were a number of basic training facilities in the area, we often saw people experiencing significant psychiatric crises. We were required to work rotating shifts. We were on 8-hour shifts at this facility, but rotated through days, evenings, and nights, sometimes doing as many as 7 shifts in a row before getting time off and then coming back on to a different shift. Military psychiatry is a bit different than civilian psychiatry. There were 2 types of patients: those with less severe mental illness like anxiety and depression, whom we would treat in street, and those with more significant mental illness like bipolar disorder, schizophrenia, psychotic disorders, and significant post-traumatic stress disorder, who would be stabilized at our facility, then sent for a board evaluation to determine if their mental illness was service-connected and they could either receive disability or be discharged from service. I learned a tremendous amount and had opportunities that generally are not provided in the civilian sector. I started assuming charge nurse duties on my unit after about a year. And after about 18 months, I was also made house supervisor, meaning I was the nurse supervisor for the entire hospital on evenings, nights, and weekends, in addition to being charge on my unit. So at the age of 26, I had a lot of responsibility. Any issue that came up in the hospital, I would get called. Sometimes it was the ED staff not being able to start an IV on a kid having an asthma attack. That was not a skill I possessed, but I got to know the ICU nurses well, and they always helped me out in exchange for my help with anything psychiatric in the ICU. If a patient needed a higher level of service than we could provide, it was my responsibility to arrange emergency air transport, usually to San Antonio. Any staff calling in sick, leaving sick, or impaired in any way became my issue to solve. Sometimes it got personal, including things like accusations of narcotic diversion at work by one of the seasoned ICU nurses, or the rapidly declining health and death of my colleague's 10-day-old infant. One of the most challenging experiences I had as house supervisor was being asked to chaperone during an exam on a woman suspected of having a miscarriage. This was one of the most painful experiences I've had as a nurse. She had already had several miscarriages, and her husband was deployed, so she was alone. Shortly after the physician began the exam, he scooted the garbage can beneath the table with his foot and began scooping large clots into it. The woman was obviously extremely distressed and crying, and I felt really helpless as a nurse. I stood next to the exam table, took her hand, and held it until they came to get her for surgery. It was many years later that I made the connection with my own experience of being scared and anxious, and having a nurse use presence and physical touch to provide comfort in a situation where words were not useful. I also had the opportunity to be part of a pilot cross-training program between psych and med-surg nursing. I went to a general med-surg unit for 3 months while one of their nurses took my spot on our psych unit. This was the unit with the 4 peds beds. I discovered that while I loved kids, I just couldn't deal with kids being in physical pain. I got a nice refresher on basic medical skills, and on nights we mixed all the IVs by hand for the next day. Lots of antibiotics, and this was in the days before pumps. I had a great preceptor on that unit and think it was a great learning opportunity for me. As I neared the end of my 3-year commitment, I was torn about whether to get out or do another tour. I was learning a tremendous amount and loved the work I did with patients. But having grown up in the Northwest, I didn't like Texas, and it was no surprise to anyone that I was as far from being a Southern woman as you can get. I had trouble with the culture, the landscape, and the climate. I also had trouble with some aspects of the military. The rigidity and structure weren't the greatest fit for me. I'm happy to take on challenges I'm asked to do if I know why and feel it is safe and within my best interest. And that is definitely not the military. You do what you are told without question. I also had trouble with the hierarchy of command, standing up when a colonel came in the room, saluting those of higher rank. For me, respect should be earned, not by virtue of one's rank or position, but by virtue of a person's essence, values, and how they treat others. Since I couldn't decide, and I wanted to go abroad, I took another assignment. I was interested in Germany, but nothing was available. However, England had an opening at the right time. So in January of 1988, I was transferred to RAF Lakenheath in a rather rural part of England, where I would be for 2 years. As a prerequisite for going overseas, I attended a combat casualty training course in San Antonio, where we practiced intubations, venous cut downs, and field chest tube insertions. The mental health unit at RAF Lakenheath was much smaller, but we were the only military mental health facility for all 4 branches of the military in all of Great Britain. If individuals could be treated within a few weeks and sent back to duty, they stayed with us. Otherwise, we sent them to Germany or stateside to be evaluated for I had participated in mass casualty war exercises once a year while in Texas. However, in England, these happened once a month. The U.S. bombed Libya in April 1986, and the attack originated from Lakenheath. Although I didn't arrive there until 1988, there was still significant concerns about retaliation, hence the increased frequency of war games. Military triage is a bit different than civilian situations because you have an expectant category. Resources are focused on those that can be tended to quickly and return to action, and then on those that don't have life-threatening injuries. Because I was a fairly new nurse, during the mass casualty exercises, they put me in the most acute medical triage area. The exercises included smoke and dud bombs going off to simulate combat. Retrieval teams would have to go into the middle of it and bring the moulaged patients back to base camp on litters, where they would be decontaminated, then triaged and either cared for on site or transported to another facility. It was extremely intense, but honestly some of the best training I had in terms of dealing with real-life medical and psychiatric crisis situations. Although I continued to grow and learn, it didn't take long for me to realize that my issue was actually the military lifestyle and that I needed to get out. I made the most of my time there, got to travel in Great Britain, Germany, Austria, and France, but I also applied to graduate school at the University of Washington and started looking for jobs. I got out in January 1990, moved to Seattle, started working at Harborview in an intensive community support program for adults with chronic mental illness, and started the Master of Nursing program in the fall. I met one of my closest friends in our fabulous cohort, who later introduced me to my husband. In March of 1992, I began working per diem as an RN at Highline Evaluation and Treatment Facility and at Harborview on all 3 inpatient psychiatric units. I finished my master's degree in June. At that time, in the absence of Doctor of Nursing practice programs in the state of Washington, a master's degree was the entry level to becoming a nurse practitioner. However, unlike the current DNP programs that provide all of the supervised hours necessary to sit for the ANCC certification exam, back then you had to get those hours after graduation. There were no ARNP certification exams at the time, and I wanted to get my certification as a clinical nurse specialist in child and adolescent psychiatric and mental health nursing. So I decided to wait until I was working in a position with teens to get my supervised hours. In September of that year, I also began working on a qualitative research project in the psychosocial nursing department at UW, coding interview transcripts of individuals with chronic mental illness about their thoughts on the recent change in mental health law that created regional support networks. By the beginning of 1993, I was looking for something more permanent and also wanted to find a position working with teens. I ultimately left all of my per diem and part-time positions to take an evening shift charge nurse position at Fairfax Hospital. Although it was on an adult unit, my hope was to make a lateral move to the adolescent unit after I had been there for a year or so. After a year, I was able to make that move and became the day shift charge nurse on the new adolescent residential treatment center. I was thrilled to finally be working with teens, which had been my goal since nursing school. About 9 months later, I made another move to become the nurse in charge of the adolescent partial hospitalization program there. In July of 1995, I left Fairfax in a state of significant burnout and decided to take a 6-month unpaid sabbatical, if you will, while trying to decide what to do next. Since I had now completed the required supervised hours necessary to sit for the certification exam, I took the exam and became licensed as a nurse practitioner in October of that year. During that 6-month break, I took several trips with friends, including one to Mexico. I repainted the inside of the house. I also thought a lot about what was missing in my work and how I wanted to move forward. I decided that I wanted to return to school again, this time for a PhD, which surprised me since I had told myself after my master's degree that I was done with school. It apparently surprised a few others as well. One of the professors I'd had in the master's program asked me if I'd made the decision to return for a PhD while under the influence of paint fumes while I was repainting the house. I suppose it's possible. I applied to the program and also reached out to former instructors at the UW, letting them know I was looking for interesting part-time opportunities if any were available. As it turns out, several very interesting things did indeed come my way. In January of 1996, I was invited to become a part of a collaborative project between UW and the Washington Department of Corrections at McNeil Island Corrections Center. They were developing a ward for offenders with significant mental illness, and our team had regular on-site meetings with staff to provide education and consultation for the design, staffing, and programming of the ward. I was a part of this collaboration for about 14 months and learned a tremendous amount. I was also asked to be a clinical instructor for a section of students completing their first clinical rotation of nursing school. Since this was a medical rotation and not a psychiatric one, I was unsure of my ability to help students have a successful experience. The number of clinical hours was dramatically more than it is today, and these were fairly basic skills, but never having been a clinical instructor in my own specialty, I was still nervous. My students and I were at the VA and had a positive experience together. They were a wonderful first group to work with. I was also asked to teach a large 90-plus theory class on communication skills in spring quarter that was a required course in the undergraduate curriculum. While I had certainly spent many hours sitting in classrooms listening to lectures as both an undergraduate and graduate student, I was quite sure this would be of absolutely no help in learning how to manage a course like this by myself. I had some guidance from the person who had taught the course previously and had a copy of the syllabus, but there really wasn't any guidance on the nuances of how to effectively teach a lecture class. There was a skills lab related to the course, so I led a section and also worked collaboratively with the faculty leading the other sections. It turned out to be an enjoyable, if somewhat stressful, experience, and I again learned invaluable skills. In May of that same year, I was also invited to join a collaborative project between the UW and the Juvenile Rehabilitation Administration. Our team conducted a needs assessment at all 6 institutions that housed juvenile offenders to determine how many incarcerated youth met criteria for a mental illness or substance use disorder, and how well equipped the facilities were to assess, diagnose, and provide treatment. After our final report was presented, we were hired to provide consultation and training to juvenile corrections officers at all of these facilities to help them work with youth experiencing mental illness and substance use disorders. I worked with this project for 6 years. During this time, in addition to the consultation and training, I was also the primary psychiatric prescriber at initially Green Hill Training School and later Naselle Youth Camp. At the end of this time, I contracted independently with the Juvenile Rehabilitation Administration for an additional 2 years to provide 6 8-hour trainings a year on working with youth who have mental illness and substance use disorders. This was an amazing project to be a part of, and I truly enjoyed all of the youth, corrections officers, and staff I worked with during those 8 years. In October of 1996, I started the doctoral program. My goal had been to finish in 4 years, since it was an added expense and cut into work time. But life happened. I lost my one remaining grandparent, I had some health issues, I got in a car accident, I got engaged, I had a house fire, I got married, and I built a new house. Needless to say, I didn't make it in 4 years. It actually took 6. But all things considered, I'll take it. I wasn't sure I was going to be able to finish it all. I successfully defended my dissertation in November of 2002 and was thrilled to be done. During the 6 years, I continued working on the Juvenile Rehabilitation Collaboration and taught the Nursing Communication Skills Theory class again in spring of 1997. After completing my doctoral degree, looking at planned reductions in my current work projects, and looking at my student loan debt, I was eager to get back to making more money and hopefully doing something I found interesting and enjoyable. In February of 2003, I applied for a half-time position as a nurse practitioner at Group Health Cooperative's Adolescent Center and was hired. Group Health was acquired by Kaiser Permanente in February of 2017. Our clinic works with teens who have mental illness, learning disabilities, substance use disorders, eating disorders, and we provide all of the gender care for youth within Kaiser. We have an amazing multidisciplinary team and do a tremendous amount of work with families and schools in advocating for the health of our teens. I'd finally found what I was looking for and continue to enjoy the work I do there. While I was interested in working more than half-time, I was not interested in increasing my clinical time. I love my clinic work, but it takes a tremendous amount of energy to be present and engaged in work with teens and families in crisis. So I started thinking about adding something non-clinical in the summer of 2004. Once again, I reached out to my longtime mentor and the chair of both my master's thesis and doctoral dissertation committees. I let her know I would be interested in being a clinical instructor for psych. I was offered a half-time psych clinical instructor position working with accelerated Bachelor of Science in Nursing students at the VA, autumn and winter quarter. I had hoped there would be some clinical work in spring and perhaps summer as well, but there wasn't anything available, so I agreed. Very close to the beginning of autumn quarter, the course coordinator resigned over a salary dispute, and I was asked if I would be interested in taking over coordination of the NCLIN 418 clinical course, autumn and winter, and teaching the psych section of senior practicum in spring quarter. This would make me full-time in autumn and winter and half-time in spring. This was way more than I wanted to take on, in addition to my half-time clinical work. But the prospect was also exciting, and I'll admit I did not want to disappoint my mentor by saying no. So I agreed, and so it began. Being new to teaching in academia, as an educator rather than a student, I didn't know what to expect. I was encouraged to ask the course coordinator who had just left for guidance, which she did not want to provide, and that I totally understood under the circumstances. However, this meant I had very little guidance, and let me tell you, it was a very steep learning curve. I enjoyed the clinical teaching, but the course coordination work was maddening. I survived the year and continued with the same roles the following year. In 2007, I continued in the same roles but moved to Fairfax as my clinical site. In autumn of 2007, I took over teaching Nursing 417, the psychiatric nursing theory course, and continued with clinical coordination as well as the psych section of senior practicum. I continued in these roles until 2013, when the number of clinical hours was decreased and a skills lab was added to the clinical course. That year I taught the theory course, coordinated the clinical, and taught in the skills lab. I've continued in these roles through the spring of 2020. Although I had previously taught the communication skills class, I felt very unprepared to take on the theory course and was anxious because I wanted to teach the content in a way that was applicable to all nursing settings and provide factual information that would help dispel myths and decrease the stigma surrounding mental illness. I knew what I wanted to do, I just wasn't quite sure how to do it. So I watched, I listened, and I learned. You, my students, were excellent teachers. I made a lot of mistakes, but you were always very forgiving. I learned to talk less and listen more. Effective teaching comes from relationship, collaboration, and mutual exchange. I learned that video case studies, particularly in patients' own words, provide an excellent foundation for understanding complex concepts in a way that lecture and reading do not. I learned that as adult learners, my students bring a wealth of personal and professional experience that deserves validation and respect. I learned that the value of an assignment isn't determined by its popularity, but by its ability to engage students in thinking critically and synthesizing information from a variety of sources. And the amount students actually learn from an assignment is directly proportional to the amount of feedback provided by the instructor. I learned it's okay not to have all the answers. I learned that regardless of what you do, you can't please everyone all the time, but you can strive for genuineness, honesty, compassion, objectivity, and fairness. I learned that deadlines are flexible. I learned that creativity in the classroom is not only acceptable, but desirable. And I learned that taking risks and being vulnerable can be strengths. Over the years, I continued to experience and witness practices in the School of Nursing that did not seem to support those of us in non-tenure track positions who provide the majority of clinical education. These things included significant inequity in compensation compared to the tenure track faculty, lack of or inadequate orientation for new faculty, lack of mentoring, lack of guidance and opportunities for professional development and advancement, lack of autonomy related to course development and selection, lack of respect for outside clinical practice commitments, and poor communication. In May of 2019, I learned that an extremely egregious policy was being recommended that would negatively affect teaching assignments, leading to loss of income and potentially benefits for the part-time non-tenure track faculty. I began putting significant effort into attempting to work collaboratively with the School of Nursing administrative team to resolve these issues. And when I had exhausted all avenues in the School of Nursing, moving to upper campus resources. Sadly, I was unable to effect the kind of change necessary to provide a safe and supportive environment for the non-tenure track faculty, one in which everyone feels valued and supported in their contributions to the School of Nursing. It is with a heavy heart that I have decided to retire from the University of Washington and the School of Nursing. I can no longer, in good conscience, continue to work for an organization that does not value or respect clinical nursing education, the dedicated non-tenure track faculty who provide it, and our exceptional students who seek and deserve it. I want to thank you, students, for enriching my life and making me a better educator, a better nurse practitioner, and a better human being. Thank you for sharing your journeys and your stories with me. Stories of heartbreak, triumph, dedication, passion, sacrifice, and perseverance. And thank you for your commitment to this wonderful profession of nursing. I will miss you and miss the amazing energy of the classroom. I will continue in my clinical practice and to provide mentoring to those that are interested. I look forward to new adventures in the next leg of my nursing journey. The world is in trouble. Nurses can and will be a large part of the solution. Patient advocacy is one of our primary roles, and this involves assessing all of our patients' needs and creating comprehensive plans of care to help meet those needs, even if we aren't meeting them ourselves. We are in an excellent position to address social determinants of health, including our crumbling healthcare system and issues of social justice. As frontline workers in the current pandemic, we are also in a position to provide factual information to the public, promote practices that increase the safety of every individual, and participate in changing healthcare policy locally, nationally, and globally. Wherever your passion lies, speak your truth, even if others aren't listening, and lead by example. Actions often speak louder than words. Work together. We have strength in numbers. And don't forget to meet your own needs for self-care and support so you can remain grounded, present, and engaged in the work you do. Strive for transparency and authenticity, so wonderfully depicted in the words of this children's story, The Velveteen Rabbit, by Marjorie Williams. This is a conversation that takes place in a child's nursery between two stuffed animals, one an old skin horse, the other a shiny new velveteen rabbit. Real isn't how you are made, said the skin horse. It's a thing that happens to you. When a child loves you for a long, long time, not just to play with, but really loves you, then you become real. Does it hurt? Asked the rabbit. Sometimes, said the Skin Horse, for he was always truthful. When you are real, you don't mind being hurt. Does it happen all at once, like being wound up, he asked, or bit by bit? It doesn't happen all at once, said the Skin Horse. You become. It takes a long time. That's why it doesn't often happen to people who break easily, or have sharp edges, or who have to be carefully kept. Generally, by the time you are real, most of your hair has been loved off, and your eyes drop out, and you get loose in the joints and very shabby. But these things don't matter at all, because once you are real, you can't be ugly, except to people who don't understand.